And he attended high school in Stamford, Connecticut, and then worked, I guess after high school, you worked as a computer scientist, or computer science.
Programming, yeah.
Did programming. And that was for IBM for 4 years. Then you decided to go to the University of Alaska, and you got at Fairbanks, you got a degree in physics and math, so those are two good subjects to get degrees in. Following college and some graduate school, you joined the Peace Corps, and you served 2 years in Zimbabwe, and that's pretty much equatorial, or is that a little bit?
No, Southern Africa.
Southern Africa,
It's
okay.
in the tropics.
In the tropics, so. And he taught mathematics at the middle school, and middle school students and trained teachers. Then he got accepted into the medical school at the Mayo Clinic in Rochester, and earned a Doctor of Medicine degree, an MD degree, in general surgery and neurosurgery. And since 2013, he's been a neurosurgeon here at the Billings Clinic. And for his hobbies, he enjoys, and pastime, he enjoys international traveling, skiing and hiking in the Beartooth, and he also enjoys going to local car shows, both as a spectator and a participant. So please welcome Dr. Mark Piedra, our speaker for this year.
Thank you. It's a real privilege to be able to talk to all these budding young scientists today, to talk about what I do and one of the tools I use and what I do. I'm a neurosurgeon, meaning I do surgery on the nervous system. And I kind of wanted to talk about neurosurgery in general because I think a lot of people have some, it's kind of a mysterious specialty. People, it's not brain surgery kind of jokes you hear about, and there's brain surgeons on TV, and sometimes it's not so real. And I kind of wanted to talk a little bit about it as a real thing. And then talk about one of the tools I use as an innovative tool. It's actually not that new, but it's incredibly innovative, and there's some very neat facets to it that I think there's some sort of takeaway lessons. And I just want to also talk a little bit about science in general, and what I think science is, and how we can be better scientists, all of us, even those that don't end up being professional scientists every day. So I do want to mention, though, that I need to warn you about a little thing, is that I'm a surgeon, and I'm going to show you pictures of surgery, and those pictures, there may be some blood, and it's surgery, okay? But I think a lot of people are interested in seeing that, and that's why I want to show it. But if you're not interested, that's okay. I'll warn you before I show you any picture like that, so if you want to look away, or if you want to close your eyes, you can do that, and then I'll let you know when the picture's gone if you don't want to look at these things. Okay, so let's talk about what neurosurgery is. What is neurosurgery? So neurosurgery is the diagnosis or finding disease and treating disease in the nervous system of the human body. A lot of people think neurosurgeons are just brain surgeons. We do brain surgery and we treat brain diseases, but we also treat diseases of the spinal cord, the other parts of the nervous system, and the peripheral nervous system, meaning the nerves that go out into the arms and the legs. And we treat even things around the nervous system, the arteries and veins. Those are important suppliers of blood and oxygen to the nervous system, so we treat those. And we even treat the bones and ligaments that surround the nervous system. So what kind of diseases do we treat? Well, we treat diseases of the blood vessels. There's abnormal things like aneurysms and arterial venous malformations. People can get strokes, and we treat those patients. We treat patients that get brain tumors, and tumors can be cancer. The word tumor doesn't mean cancer by itself. Tumor just means an abnormal lump of something, and it can be cancer, or it can be not cancer, or a benign thing, and we treat those. And those can be in the brain, they can be in the spine, they can be in the nerves, and we treat those. We treat trauma to the nervous system, the brain, the spine, or the surrounding tissues. We treat functional disorders, things like tremor, people who have a bad shape. We can treat that with neurosurgery, or different types of movement disorders, people who have spasticity or very stiff problems with walking and doing things, we can treat that. And people who have seizures or epilepsy, we treat as neurosurgeons. And probably the most common thing we treat, which is a surprise to a lot of people because they think neurosurgeons are brain surgeons, but probably the most common is actually degenerative spine disease, meaning spine problems from just wear and tear, and people who, you start to wear out and you get pressure on nerves, and you need to get that to get treated. And we also treat peripheral nerve disorders, meaning problems of the nerves that are outside the spinal cord and the brain, And probably the most common is carpal tunnel. Probably a lot of people have heard of that disease, for example. There's lots of others, but that's one of those things that we treat as neurosurgeons because it's part of the nervous system. So what's it like to be a neurosurgeon? Well, neurosurgery is one of those crazy specialties in medicine because we get to do some really cool things. You know, I get to touch the brain almost every day if I want to, in a way. I get to, with my own eyes, see where thought and memory and get to touch it and manipulate it and move it, and it's quite a privilege to do that. But because of that and the nature of neurosurgery and the emergencies and things that go along with it, it's extremely busy. As a neurosurgeon, I work easily 70 hours or more a week, and sometimes 100 more hours a week, and it's just the way it goes. It's one of those things, it's not, I don't do that because I love to work, but it's because once we start, we have to continue. If I take out a brain tumor in someone, I can't just, say, see you later, and I'm gonna go, to the bar and have a drink, and I'll see you. No, I have to be prepared for whatever might come next, and that could be in an hour or a day or 2 days, and I have to be around to take care of those issues when that happens. So it's a very busy specialty, but it's very intellectually stimulating. I get to work, the other neurosurgeons I work with and neurologists, those are doctors that work with the nervous system but don't do surgery, they don't open you up. And we get to talk about very intellectual and things, and innovative things. And plus all the other doctors and all the other providers of healthcare, we interact daily, and you learn every single day, something new, and that makes the job rewarding. It's very rewarding when things go well in neurosurgery, when you can help someone who can't walk to walk again, or someone who's going to die of a trauma and you save their lives. But sometimes things don't turn out so well, and you think you're doing the right thing, and you do the best you can, and it doesn't come out right, and someone can't walk again, or they die from what you've done when you're trying to save them, and that can be very hard. And so it's a very up and down kind of job, I'll put it that way. But it's also humbling to see people who have to go through these terrible ordeals of brain tumors or trauma to the nervous system, and yet they rebound, and they're just amazing, and it's a wonderful thing to be able to work with them. So how do you become a neurosurgeon, if anyone's interested? It takes a while. You go to college, that's 4 years degree, maybe more, depending on what kind of degree you get. Then you go to medical school, it's another 4 years, there's lots of books and studying, and a billion tests, more tests than you could ever imagine. And then you got to do general surgery. That's just to learn how to take care of patients who have had any type of surgery, have their gallbladder out. Even though I don't take out gallbladders, I kind of know how to take care of someone who had their gallbladder out, because you learn that as a general surgery intern, they call it. You do that for about a year, and then you do another 6 years just training in neurosurgery, learning about neurosurgery patients, learning how to operate, how to actually physically operate, learning how to take care of problems, how to expect problems, and be prepared for problems in neurosurgery. And then sometimes people go on for another year or two doing more training in neurosurgery, which is crazy. But they do it, and so it's a long, long road to get there. And then you finally get out there and do it, and you think you're all done with your tests and your learning, but no, it continues on forever, because we have to continue to take tests. They don't want neurosurgeons out there that aren't learning new things, and they don't want neurosurgeons who have forgotten things that are important. And so I still have to take tests, and I still have to learn new things, and it never ends, in all honesty. But at the same time, like I say, it's a very rewarding job, so I love it. I get to work in cool places like the operating room here. This is kind of my home, and I love it. It's a big team approach here in the operating room. Lots of people working there. We have the surgeons there, but I have an assistant who helps me in the surgery. And then we have an anesthesiologist who takes care of the patient when they're asleep, and there's nurses of all types that help with just how things flow in the operating room. I use cool toys like microscopes and all sorts of crazy things that we get to use in the operating room. It's a fun place to be. And so that's what I love about the job. I'm not going to show you the things I hate about the job, because there's those too, unfortunately, like every job. There's things you hate about it, but the operating room is the place that I love. So let's talk about what kind of things I do in neurosurgery, and one is, for example, take care of patients with tumors. And here's an MRI of a patient with a, whoops, sorry, I was going to warn you about that picture. I was trying to get my little light up. There we go. So this is an MRI of the brain, and this patient is a 70-year-old man who had some tingling in his arm, and his doctor ordered an MRI to look at what might be going on, worried about a stroke, actually. But it turned out, no, there was a tumor. This white thing here is a tumor. And so I had the privilege to go and take this tumor out of this patient. And so the next picture is a picture of the tumor. There's a little bit of blood there, so if you don't want to look at it, close your eyes. But it's not really that bad at all. It's a fine picture. So here's the tumor after we took it out. This part of the tumor here is the covering of the brain, actually. It's called the dura. It's not tumor, really. It's the covering of the brain. And this is the tumor part, this little ball here, and that's the tumor we took out. And he did well and went on his merry way and never had any further problems. He still gets followed just in case this kind of tumor grows back, but it's a benign tumor. It's not cancer. Once we take it out, we're done, and we've treated the problem. Then we can also take care of malignant tumors or cancer tumors. This is a very odd one. This is one of a rare one, but we see these from time to time. This one's called Ependymoma, and it's this kind of bubbly thing here. And this was unfortunately a young woman and who had headaches and some weakness of one of her legs, and sure enough, she had this tumor. And so I'm going to show you a picture. This one's a little more graphic, so if you don't like graphic surgical pictures, this is in the surgery. We took this picture. And what this is a picture of here is this is the scalp opened up, and we removed a section of bone. This is normal brain right here in this little part. And the tumor sits right here. This is the tumor. And this is right before we're going to proceed to take that tumor out, which we were able to do. She did fine from taking the tumor out, but unfortunately because it's cancer, she did require more treatment, things like radiation therapy, and I'll talk a little bit about that in a bit. So that's one of the, again, it's something that I get to do. Sometimes we have tumors of the spinal cord. Like I said, it's not just all the brain. So here's a tumor in a woman. This is an MRI of the spine. The brain is up here, and this is the spinal cord, and there's a big tumor here sitting in front. And again, here's another graphic picture, but not so graphic here. It's kind of a cool looking picture. And this is during surgery, intra-operative picture that we take. I operate on this under a microscope. What we're seeing here is the spinal cord. So her head is up here somewhere, but this is the spinal cord. All this tissue, there's a big artery right on the surface. And the tumor is right here. It looks like a kind of a cluster of grapes. This wispy stuff here is what we call arachnoid. It's part of the covering of the spinal cord. We call it that because it looks like a spider's web. But it's just one of the coverings, one of the layers of the spine, of the spinal cord. But anyway, this tumor is a benign tumor we were able to take out, and she did just fine. Okay. I also take care of trauma. Oh, no, look at that. Let me just go there. Anyway, I take care of trauma. This is a person who was in a car accident and has a very bad broken part of the spine. This is a CT scan. We're looking at from the side. These are the vertebrae of the spine, and there's a badly broken part of the spine here. This is unstable. This person can't walk at this point, not because their legs don't work, but because if they tried to walk, the spine would collapse. The body is really amazing in that if you had this fracture, you wouldn't be able to walk either. Not because your legs don't work, but your brain would say, don't try to walk, because I know this injury is so bad that if you tried to walk, your spine would fall apart. So it kind of stops you. The brain is an amazing thing. And so another sort of graphic picture, but not really. I used a special technique to fix this fracture called Stereotaxis, and I'll talk a little bit about that. And it's to stabilize the spine. And here I am in the operating room with my thumbs up saying, yeah, we're done, and we were able to stabilize the spine. And really we did this through just several small incisions. And in the end, about 6 weeks later, this is what it looks like. We were able to stabilize it with screws and rods. The fracture is now healing, looks much better, and the patient is able to walk. As soon as the operation is done, they're able to walk. And the point of it is that I did this all without actually being able to see what I was doing, so to speak. I'm doing it through a technique called stereotaxis. And I'll talk a little bit about that because gamma knife plays a big role in that. And, but it's a technique where I can just make little holes and be able to operate without actually having to see what I'm operating on, if that makes sense. So next one is another little graphic picture, just to talk about peripheral nerve things outside the brain and spinal cord, where someone had an injury to a nerve in the arm, they couldn't use their hand, and we were transferring a working nerve onto the muscles that were supplied by the nerve that was injured. Okay, a nerve transfer operation, a little bit graphic photo, but just to show that we do work outside. Here's an arm, and we've opened it up. We're looking for nerves now to find the bad nerve and the good nerve, and we're going to tie those two together, okay? We're done with that picture. I also treat vascular things. This is a vascular malformation, an abnormal tangle of blood vessels in the brain, and so this is an artery, and these are all arteries. Then all of a sudden we have this abnormal tangle of blood vessels, arteries and veins. This is sort of a ticking time bomb of neurosurgery. This thing can just rupture and bleed at any moment, and you would die from that if it were to happen. So we have to take that out. Next picture is a little graphic, so if you don't want to see it, close your eyes. And this is the intraoperative photo. We're looking at that vascular malformation here. What I have here on the brain is a wire, and what I'm searching for is I'm looking for what we call the motor strip of the brain, or the part of the brain that serves function of being able to move the body. I don't want to harm that, so I need to know exactly where it is, and I use some special electrical studies to do that. And once I know where that is, then I know what parts of the brain I can manipulate without harming that part of the brain. But the malformation is right here. You can see one large vein coming right off of it. That's that one right there that you see on what we call the angiogram. This is called an angiogram. That's the large vein, and we can see it right there. Okay, but we were able to take that out, and that patient did just fine. And another thing that we might treat, an infection in the brain, and this poor person had a very bad ear infection. This is very rare. I'm sure people get ear infections from time to time, so don't think you're going to get a bad brain problem from an ear infection. Very rare for this to happen, but it can, where an ear infection led to a terrible brain infection. So this is another MRI, and there's all this area here of stuff on the surface of the brain is infection, okay? And this is quite a graphic photo, so if you don't want to see it, close your eyes. But this is intraoperative of me taking out the infection, and here we have the brain. It looks terrible because it's completely swollen and red, and this is the covering of the brain, all covered in infection, just pus essentially. And again, this is an emergency surgery. We had to do this in the middle of the night, but this patient in the end did very well and is doing fine. This is the kind of life-saving operation that, while it wakes you up in the middle of the night to do, it's very rewarding when it goes well. Okay, the ugly picture's gone. But things don't always go so well. Here's an MRI of a patient with a very small tumor, and unlike those other ones I showed you that were big things, this is just a little thing, and this was, I feel like, oh, this should be easy. I'll just take this little tumor out, and I took this tumor out, but unfortunately, it didn't go so well, and this person who had no problems before then ended up with weakness in their hand so much so that they couldn't use their hand, So this is where you feel terrible here. I tried to help, and I hurt them. Now, we got the tumor out, and that's important, and it was cancer, but at the same time, if I can't help them or make their life at least the same and not worse, what's the point of what I'm doing? So this is what makes the job very difficult sometimes. And I'll use this as an example because Gamma Knife is perfect for this type of problem, and I'll talk about it in a second. And surgery is destructive. Here's a young man, he's only 19, and he had this big tumor. Now, we were able to take it out, and it went fine and everything, but when you look at his MRI afterwards, to get it out, we have to go through all this brain, and we have to manipulate that brain. He was fine, he could walk and talk and, play music and the things that he did before, but you can't help but wondering, in the long run, now that I've damaged this part of the brain from going to take that tumor out, there's likely to be some effect. I don't know that I can measure that effect, but if we could somehow get this tumor out without having to go through this corridor of normal brain, that would have been probably better, And that's what I'm getting to, sort of this innovation, saying what we're always trying to do as surgeons is find less invasive things that will have lower risk or harm the normal tissues less. And Gamma Knife is one of those innovations that we have. And that's part of science, right, in trying to discover those things. And what is science, okay? So there's lots of definitions and whatever that you can find about science, and all you guys are scientists, because presumably all of you, or most of you here, did a science experiment, and so that's science. But in all honesty, you do science every day. Because to me, what science is asking a question, and then figuring out the answer, and then telling someone about it. And so even when you make a recipe, you're cooking something at home, you're doing science. You're like, does this need some more salt? Yes, it does. And then say, hey, I put more salt in the stew. That's science in a way. It's not, earth-shattering, but that's what it is, and that's what science is. And so, you can think of science as just every time that you have a question about something and figure out the answer. Now, sometimes you're just figuring out the answer by reading in a book. Now, maybe that's not quite science, but in a way it is. It's a method of determining something new to you. And the important part also, though, is the end part. Is if it's just new to you and you don't share it with anybody else, well, it's not science. You got to share it for it to be science, in my opinion. Because that's the whole point, is that other people learn from what you just learned. Okay? So that's science. So, there's big fields of science, biology, physics, and chemistry. Those are these huge fields of science, and everything's based on that. And not everyone here is going to be a biologist or a chemist or a physicist. although some of you probably will be, and I hope you do. It's a great field. I did physics, although I'm not a physicist, but I learned physics and I loved it. It was very helpful. But the important thing is that there's all sorts of other fields that are a part of these major pieces of science. And they can even be things like applied science, like engineering, or math, well, math not really applied, but theoretical, like math, or things like biomedical engineering, electrical engineering, that really are science in a way. You're building something and you're trying to figure out how to do it in the right way. You're asking a question, you're figuring out the answer, and then you're sharing it, whether it's the product. And in some ways, like I get to treat brain tumors with Gamma knife, and I'll talk about that, how I do that. But when I treat, I did two patients today. Okay, so I got to treat 2 patients with a Gamma knife today, and that's great. It's very rewarding, and I enjoy doing that. But the guy or gal who wrote the software that I use, well, she got to treat, probably 500 patients today, because it wasn't just my Gamma knife that I used the software on, but it was the Gamma knife in Seattle and the one in Portland and the one in New York, and all those Gamma knives use this piece of software that this person created, and they get to treat all those patients every day, maybe not directly, but indirectly. And I think if that's the kind of work you want to do, even if you're not going to be a doctor and treating people directly, you can still benefit healthcare or whatever it is by your inventions and your innovations. Okay, so that's enough about science. Gamma knife. So Gamma knife, we call it brain surgery without a scalpel because we can take out tumors and we don't have to cut open the head, and that's kind of cool. There's no blood, there's no cutting, and there's no anesthesia. The people are awake when we do this. They don't have to go to sleep. You don't stay in the hospital. You just come in, and you get it done, and you go home, and you just go back to whatever you were doing before. So it's kind of neat. It's a form of stereotactic radiosurgery. These are 2 big words, and I'll talk a little bit about what they mean. Stereo is a Greek word. It kind of means space or dimensions, okay, 3 dimensions. That's where the word comes from. And so what we're talking about is we're using a 3-dimensional space, and what we're, in this case for the Gamma knife, talking about the head. It's a 3-dimensional space. But we're using that space in a different way. So we're taking the space of the head and coordinating it with or referencing it to another space, a frame, and I'll show you what that is in a second. And then radio is just pertaining to radiation here when we say radiosurgery, not a radio like the car radio, but radiation, and that we're using radiation to treat the tumor. And then surgery, which is really a violent way to do things. We just use that term because it's like surgery, but it's not violent at all, as you'll see, and I'll show you. So what's stereotaxy? This is a kind of a funny diagram I use a lot because this is stereotaxy in a way. And what the idea behind this concept, a very smart man named Lars Lexell kind of figured this out. And he said, well, if we can create a frame around someone's head in which a tumor, so here's someone's head, and here's a little tumor here, this little circle here, is at the center of the frame, and then we have a curved arc here. Okay. Anywhere on this arc, and it doesn't have to be an arc, it can be a sphere, but anywhere on this arc, that tumor is always at the center, because the center of a circle is always the center, no matter where you are. If you're here, that's the center. If you're here, that's the center. So the key is to just put this tumor at the center of some frame. Okay? And that was his concept. And he first did it so that he could stick needles in the brain and take out tumors, or at least sample tumors, biopsy tumors. But then he realized he could also give radiation in this technique, and I'll get a little more into it. So here's it in real life, the real frame, because it needs to be in 3 dimensions. And this is a frame. This is actually not the Lexell frame. He invented his own frame, but this is one like it. It's called the CRW frame. But what this is we've attached these things to the patients, okay? These posts, okay? Don't worry about the rest of it. These posts are the key to the whole thing. Those posts don't move. But we can see those posts on the patient, and we can also see them on an MRI. And so if we know where the tumor is, because I can't see the tumor, right? The patient has a tumor, I can't see it. The skull's in the way. I don't know where it is, but I can see it on the MRI. So if I can see where the patient's tumor is on the MRI, and I can see where the posts are on the MRI, well, all I have to know is how far is it away from the posts to figure out where the tumor is. And that's how I can direct my treatment or biopsy or whatever it is. And that's the concept, and that's this idea of stereotaxis. So radiation to treat tumors, it's been around forever, since X-rays were discovered, more than 100 years ago. they were used to treat tumors. It works because tumors don't respond to radiation very well, most tumors. And when we're talking about tumors, we're talking typically about cancer, but not always. But cancer especially, it doesn't respond to radiation. It gets damaged by radiation in such a way that it can't repair itself. Our normal tissues, I know you hear about radiation, it sounds scary, but our normal tissues actually are very good at responding to radiation, and we can repair ourselves. So when the radiation damages the tissue, it can repair, but the tumor, it can't. And so if we give radiation, the purpose is that our normal tissues that we don't want to hurt repair themselves, while the tumor tissues get hurt and can't repair themselves, and they die. And that's how radiation works. So we treat tumors and cancer with radiation all the time, all over the body. Gamma knife, we just do it in the head, but I'll talk about a little bit about other things, uses of radiation. And what it uses, the gamma knife itself uses actually a special kind of radioactive source. It's of metal, it's called cobalt. It just looks like this if you just picked up a piece of cobalt. You don't just pick up a piece of cobalt, it comes from mines, usually aluminum mines, but it's just a piece of metal. It doesn't have radiation actually when you get it out of the ground. We got to make it give off radiation. And we do that by turning it into a special isotope, meaning a special form of cobalt that's not stable. It's called Cobalt 60. This is, one of these fancy, the physics guy I know is smiling because he loves these diagrams, but most of you are probably like, what the heck is this? It's just a bunch of numbers and letters, and even Greek letters like that, and like that. Well, what this is a diagram is just showing you that Cobalt 60 is a isotope of cobalt that's not stable. It decays. It actually turns into nickel, another metal, which is stable. This is normal nickel. And when it does so, it gives off gamma rays. It gives off a beta particle too, but it gives off gamma rays, and those gamma rays are what we're using to treat the tumor. Okay? There's another important number on here, is this one. That's the half-life of this cobalt, meaning once we have a radioactive Cobalt 60 source, in about 5 years, it's only producing half as much gamma rays as it was when we first got it. So, but either way, that's the idea. Cobalt 60 produces gamma rays. And here's the machine. This is the gamma knife machine. This is a bed. Person lies in the bed. Remember I talked about that frame attached to the head? That frame is attached to this little thing here. So their head is sticking out here. Inside this huge box, which weighs 20 tons, is mostly lead shielding to prevent the radiation from going everywhere, is 192 pieces of Cobalt 60. And they're arranged almost in a sphere so that as the gamma rays that come off that Cobalt 60 all cross right in the middle at one little spot. And if we could put the tumor at that one little spot where those 192 sources of gamma rays cross, then you get a very high dose of radiation there. And that's the concept. Here it is in another engineering type diagram. Here's the bed. Here's the area where the head goes in here, and the sources of radiation come from all angles. And I think, here's another little picture. Here's the person with the frame on their head and all the sources of radiation coming, all the gamma rays. Each of these little boxes would be a piece of Cobalt 60 that's sending out its gamma rays. And we have 192 of them in the gamma knife machine. And so you can imagine each individual ray is not that strong. It doesn't have that much radiation to it. But when you have 192 of them crossing all at one point, well, it's very strong. Okay? And that's why we can kill that tumor. And in the meantime, if you see this, is that through the normal brain or normal tissue, there's only one ray going through here, one through here, one through here, one through here. So each normal part of tissue doesn't get very much radiation at all, while the tumor gets a lot. So 192 individual sources. Each gamma ray we can consider it a low dose, so it's hard to say that in radiation in any way, but it's a low dose. But when the 192 cross, you have lots of radiation, and that's how it works. So we get a minimal dose of radiation to the normal brain, and then a high dose of radiation to the tumor, and we can kill the tumor. So here's how we do it. We put this frame on the person's head, and that's to prevent the head from moving. We need to use this as a reference. The frame is the reference that we're using to treat, because we can see the frame on the MRI, and we can see the tumor on the MRI. because otherwise I can't see where the tumor is. I need some reference, and that's what the frame is for. And here's the patient inside the MRI machine. Well, it's actually a CAT scan, but same kind of deal. There's a frame. We have this plastic box at this point, but there's the frame attached to the patient's head. And on this MRI, you see these little dots? Those are the posts. So as long as I know where those posts are, well, then I know where the tumor is in relation to those posts. So I don't care where I don't care that I can't see the tumor, because I know where it is in relation to those, and that's stereotaxis. And so what we treat with a bunch of shots, and each shot is just the patient going to a specific position in the machine so that all those sources are crossing somewhere, maybe here, and then it moves over a little bit and does the next one, and then it moves over a little bit and does the next one, so that it can form a tumor that is odd-shaped. If it's a little tiny ball of tumor, we just need one shot. It's treated, it's done. But if it's funny shaped, well, we put a bunch of balls together and treat the tumor. And we shape it by collimators, so we can make things that are oval or star-shaped or whatever. And as we combine this together, we can create a what we call a conformal shape to the tumor. We can conformal radiation to treat the tumor. It looks just like, the dose of radiation looks just like the tumor. And this is, of course, done by very fancy computer programs that help us do that. So this is a little gamma knife video. It's not, let's see. Yeah. Sorry, this is kind of like, this is from the company who makes the machine, so it's a little like rah-rah, gamma knife is great, okay? But this is inside the machine. These little holes are where the gamma rays are going to go through. So it'll go through a treatment here. So there's the gamma knife unit, there's the patient with the frame on their head, okay? Now the doors are opening, we keep the doors closed so that we can go in the room, so we're not getting radiation when we go in the room as providers. And they go inside the machine, and now, once they're in the machine, they're getting a dose. Now they're going to move so that the tumor's in the center, and then they move again for maybe another tumor, or perhaps another part of the same tumor. Meanwhile, we sit outside of the room, us doctors and physicists that are treating the patient, we sit outside the room. We can see the patient on a video camera, but otherwise they're just in there. And we don't have to move them or control anything. We just shape out the tumor. We say deliver the radiation. We tell it how much to deliver. We push the button, and in they go. They move around a little bit. Tumor's treated. The patient comes out. We get the patient up. We take the frame off their head, and they go home. There's some other aspects to it. We have different size collimators, meaning we can put big shots or little shots. We can, like I showed you, shape them in different ways, and that's kind of what it's showing here. That these little doors slide back and forth inside the machine to deliver precisely the type of radiation we want. So there's a picture of a brain, and they're treating some little thing down in the brainstem here through these individual gamma rays, and it may require multiple shots. It almost always does, except unless they're very small and very round. Can we treat it with one shot? And so we can treat multiple tumors in the same session, meaning we just see there, now it's going to treat this tumor up here, and that's how it goes. You can't see these gamma rays in real life, of course, it's just showing you them. And then it may go and treat another tumor. But the patient doesn't have to come back. We can treat them all at the same time. Multiple tumors in the brain are common in certain types of cancers. Things like lung cancer can spread to the brain, and people will get 4 or 5 or sometimes more tumors. And so the tumor can be shaped differently, and you see they did one shot there, another shot here, another shot will go there, and even though the tumor is shaped in a funny way, it's not perfectly round, we can still treat it and give all the radiation dose we need to kill the tumor, and in the meantime we haven't harmed the normal brain. And it is just pretty much a single push of the button after we do all the planning. It's a little bit more than just a push of the button. Anyway, so that's the little video from the company that makes it, so sorry that's kind of advertising there, but how well can we do? So here's a patient. This patient has lung cancer, and lung cancer is now spread to the brain. And they have some tumors, a good sized one here and a little one here. Okay. What else we see here is this darker part on the MRI. That's swelling. That's the brain's reaction to the tumor. The brain will swell. We call it edema. And sometimes the edema is has more symptoms than the tumor itself. And So it was gone. 3 months later, after the treatment, gamma knife treatment, this big tumor has just turned into a tiny little wisp of things. This tumor is completely gone, and there's no edema anymore. We treated. We didn't have to cut them open. They did this in 1 day, and it's gone. So it's pretty spectacular. Here's another of the same thing. 2 tumors here, and before treatment, and again 3 months later, we can't even tell. The tumors are gone. Never had to get cut open. Never had to stay a day in the hospital. It's quite remarkable. Sometimes we treat benign tumors. Those are cancer. This is a common benign tumor. It's inside the part of the ear. The ear is here. And this is on the nerve that goes to the brain through the ear. It's called the vestibular nerve. It's called an acoustic neuroma. And this one, when it's benign, we tend to be a little less aggressive. And we give it less radiation. Because we don't want to harm the normal brain around it. And it's not cancer. So we give it less radiation, but still 9 months later, clearly now we've turned it from this big white ice cream cone looking thing, and now it's starting to die away. It's starting to turn black. And probably in another 9 months, it'll be even more black till it's gone and you can't see it anymore. And so we can treat benign tumors. And we can treat other conditions. Remember that guy with that arteriovenous malformation, that tangle of blood vessels? We can treat those with gamma knife. We can make those disappear and not have to cut open the brain and expose it like that. We can treat facial pain. There's a thing called trigeminal neuralgia, a disease called trigeminal neuralgia. It's quite common. It's devastating. People kill themselves because the pain is so bad. And we can treat that without having, the normal treatment is cut open their head and go into the brain and treat it, but we can treat it with the gamma knife without having to use a scalpel. We can treat tremor, people who have a bad tremor. We can treat that. The old way of treating tremor, still done, I shouldn't say old, but still done, but a more invasive way is this. Here's a patient. Notice he's got the same frame. That's the interesting part, because we're using stereotaxis. But instead of treating with gamma knife radiation, this surgeon, this a colleague of mine, he's actually going in there into the brain with a wire. So he's going to cut this open, drill a hole in the head, stick a wire in deep into the brain, and burn a little hole in the middle of the brain to treat the tremor. It works. The problem is, this patient is elderly. He's probably 80 years old. This has to be done awake. He's not sleeping. He has to be awake. So he has the frame on. This frame is put on awake. He's affixed to the bed. He can't move for about 3 or 4 hours while this is done. He's getting his scalp opened, hole drilled in the head, a wire set deep down into the brain while he's awake. And so a lot of people don't want to do that. So if there's some way we could do that without doing that, well, we do. We have the gamma knife. And so here's a patient we treated with tremor. And the reason why it's hard to treat with that wire, and it's so invasive, is because where we're needing to treat is right here, this little tiny spot in what's called the thalamus of the brain. If we can treat that spot and kind of kill it, we can stop the tremor, and that's quite effective as well, as opposed to burning it with a wire like that we're doing in that other guy. Okay? So gamma knife radiosurgery, there's lots of things we can do with it. We don't just treat tumors, but that's the mainstay. Okay, we can treat, again, cancers, non-cancers, the vascular malformations and things like that. It's extremely precise. It's within sub-millimeter accuracy, about half millimeter accuracy to deliver that dose of radiation. So we have a very sharp dose fall outside the target lesion. What that means is that the normal brain around the tumor, or the area that we're treating, does not get a lot of radiation. And that's obviously a great benefit. And it's been used actually for a long time. The machines and the software have improved tremendously, and that's the innovation. But the technique is from the 1950s. The idea, it just took a lot longer to do it back then when they didn't have computer software to help us. Didn't have MRIs. Didn't even have CT scan. Had to do it with X-rays and things called pneumoencephalograms, these painful tests to do to get diagnosed. But as we innovate, things become less and less invasive, and we hurt people less when we try to help them. So getting back to that science thing again, this is innovation. Ask a question, find an answer, however you do it, and you all did it in your science experiments, and then communicate the results. That's the other most important thing, but that's kind of what you're doing here. That's why you have a science fair, because you didn't just do an experiment and then kept it to yourself, but you shared it with everybody else, because then they take that piece of information and build on it from there. Okay? So science is questions, asking and answering. So I'll answer some questions. Does anybody have any questions about neurosurgery, gamma knife, Zimbabwe? Yes?
How much does that cost, like, to select politicians?
How much does it cost is the question, to treat someone in the Gamma Knife? Good question. It comes up occasionally. Healthcare costs are unusual because doctors and patients and nobody knows what they cost. It's a very complicated system. But because we have a Gamma Knife here in Billings, there are some Canadian patients who are waiting for treatment in Canada, which has a very different healthcare system, but they want to be treated sooner. So they come on down with cash. And we typically charge them $20,000 to $25,000 for one treatment on the Gamma Knife machine. It's not cheap, unfortunately. Yes, you have a question?
Would it be painful for the elderly?
To do Gamma Knife? No, most of the people we treat are over 65 years. That's not elderly, that's just, beginning of... But, is that what's that? The drilling. Well, so that's interesting. This is a fascinating thing. The scalp, the covering of our head, has lots of nerve endings. And to cut that open, it's really painful. I'm sure you've had a cut before on your face or your scalp, and it hurts. Well, we can numb that up. So we can use numbing medicine and numb it up so that doesn't hurt. But interestingly, once we get below that, and we go through something called the periosteum, which is a thin layer that covers the skull, there's no nerve endings anymore. So we can drill, apart from the sound, which nobody likes, we can drill a hole in the head, it doesn't hurt at all. It doesn't hurt at all. There's no nerve endings there. The covering of the brain also has some nerve endings, but they're different. They don't seem to cause pain when we cut them. They do cause pain other times, but once we're in the brain, there's no, even though there's a lot of nerves, there's no nerves that sense pain. So you can do all you want in the brain, in people who are awake, and we do this sometimes not just for that disease, sometimes we have to do surgery in the brain when the person is awake. And we can talk about that too, but it doesn't hurt at all, because there's no pain fibers, there's no pain sensation. There's nerves, but not pain. Yes? How many people? How many people have we treated with a Gamma Knife? So far we've been operating 2 years. I think we did patients 123 and 124. So we do about 60 plus a year. We'll be doing more because in our first year we were a little slow because it was new to us. But now we're doing more. So we'll probably doing 70 or 80 people every year. Yeah. Good. Yeah, so there's two good questions. Can little people do it too? Yes. There's no reason why if we needed to treat someone small, a child, or just a small person, yeah, we can treat any size. We cannot treat other parts of the body. And the reason is, it's important that we have that frame, okay, on the body. And we can't really put a frame on the body. Now you can, but then you wouldn't fit in the machine. So the machine was designed, the Gamma Knife machine was designed to be kind of a sphere. And the nice thing, our head is kind of a sphere. So that's why we treat the head. We can treat some of the upper part of the neck, but can't get much lower than that. There's other machines that can do it, very similar things though, and treat other parts of the body. Yeah? Does it do? So if we had to drill through the skull, well, apart from putting a hole in it, no, there's no other damage. It doesn't crack it or anything like that. Over time, the body will fill that hole in, and new bone grows across that. It takes a while, though. It takes a few years for that to happen. Yeah?
How long does a Gamma Knife take to operate?
For treatment?
Yeah.
So it depends on what we're treating, how many shots, individual shots, and how much dose we have to give. And the dose varies between the kind of treatment we're doing, the kind of tumor it is, or if we're treating other types of disorders. Sometimes it takes a long time. I would say on average it's about 45 minutes to an hour that the person is in the machine. Okay? There's a lot more to it in the day because we have to put the frame on, we've got to get the MRI, the CT scans, and we do all the planning, and that takes time. But in the machine it's really only about 45 minutes. Yeah? That's right, there's no knives. We only call it Gamma Knife because you saw the pictures where we could go, and it's almost like we used a knife, but we didn't. If we go back to not that one maybe, but that was not a good one either. But this one. So, you can imagine, look, there was a little tumor here. Now, I could have cut that out. That's surgery that I would do if I needed to cut it out with a knife. But I didn't have to cut it out with a knife. I made it disappear without a knife. But we do call it a knife. Yeah?
So, when you get a CAT scan, are most people awake or asleep?
For a CAT scan, most people are awake. For an MRI, which takes a lot longer. CAT scan is an X-ray, a special kind of X-ray. It takes really about 30 seconds. Doesn't take long. MRI takes maybe 20 minutes to get an MRI of the brain. So most people don't need to go to sleep for that. Some people do because they just can't stand still. They don't like that they're kind of inside a machine and they have claustrophobia. So sometimes people go to sleep. Little kids, like sometimes if we need to get an MRI on a little, someone who's 4 or 5 years old, it's hard for them to stay still for 20 minutes. So sometimes we put them under anesthesia. We let them sleep and get the MRI and then wake them up when we're done. Yeah? Yeah?
Has the gamma knife ever not worked?
Good question. Yeah. Now sometimes some tumors don't respond to radiation. And in that case, the gamma knife may not help. Other times what happens is that the gamma knife radiation itself causes some swelling in the brain, and that swelling is bad enough that people can't deal with that, and so they get worse instead of better, is what I guess I'm saying. So that's not really working then, right, if we're trying to make them better. So yes, sometimes, but most of the time it works. Just like surgery, most of the time it works. Not always, unfortunately, but most of the time. That's why we do it, and that's how we choose what to do. We only choose the things where we feel like we have a much better chance of helping than of hurting. Yeah?
What brain growth the first time you saw it?
Say again, I'm sorry.
Was brain growth the first time you saw it?
Well, no, I thought it was fascinating the first time I saw it. I think the first brain I saw was someone who wasn't alive, because in medical school you do anatomy, and we use people who have already died, and we study their bodies. So that was probably the first brain that I saw. And maybe in school, even if you don't become a doctor, you may take a class where you'll see a brain. Maybe first a cow brain or a pig's brain or something like that. But then, so no, I think, if it's gross to you, which for some people it is, that's fine, then maybe brain surgery is not for you, that's okay. But if you're fascinated by it, well, look into brain surgery. It's fun. What time is it? We got a couple more minutes, I suppose. Yeah, and all the way over there on the... Yeah, that's you.
Do people that have tumors, and when you take them out, do they have memory loss?
Well, I hope not, but sometimes they do. Most people don't remember, or I should say nobody remembers getting the tumor taken out, and most times they don't have memory loss. They can for a short time afterwards, for a day or two, kind of forget where they are and what's going on, but then over time their brain kind of kicks back into gear and figures that out. But unfortunately, like I said, sometimes it doesn't always go well, and people can have permanent memory problems from brain surgery, and that's why we like things that are less invasive, like gamma knife. Yeah.
So why, when you take an MRI of the brain, why is there the little black spot right in the middle?
Okay. So you mean these things here?
Yeah.
Yeah. So that's normal. Those are fluid-filled spaces of the brain we call ventricles, and they're just a normal part of the brain. I wish I could tell you exactly why they're there. Sometimes they themselves cause problems. Something called hydrocephalus is a common problem that we treat. But that's just that's normal. It's a fluid-filled space. So the brain tissue is all this surrounding stuff, but this is just water. Inside are these little wispy things, we call them choroid. That creates the water, actually. This is like in other parts here we're looking at, this is a big vein. It's called the sagittal sinus. You can see some smaller arteries. These little dots, bright dots, are arteries. Part of being a neurosurgeon is being an anatomist. We have to know the anatomy of the brain very well, know how to read the MRI and determine exactly where something is and what's nearby and what's important obviously all the brain is important, but some of it's less important. Like you can see when I took out that one tumor and I had to go through part of the brain, I chose the part of the brain that I knew would have not much effect on the person. Now, is it still destructive and may have some long-term effects? Yes, but in the immediate term, they're not going to wake up and not be able to think or not be able to walk or something like that, because I know which parts are safe to do that to. Yeah, in the blue. Yeah.
Okay. How many people are in the operating room at a time?
So in an operating room, when I'm doing a brain surgery, like taking out a tumor, so I'm there and I have a surgical assistant. She helps me. She does some of the surgery with me. And then we have a scrub nurse. That's a nurse that is scrubbed in with me, meaning they're sterile, right? And we have to be sterile. We don't want to cause an infection. And so they're sterile, and they're handing me instruments and preparing certain things that we're using in the surgery. Then there's what's called a circulating nurse. That's another nurse in the room. And that nurse is not sterile. And her role, or his role, is to get things and give them to the scrub nurse in a sterile way. So that I say, oh, I need this, and they say, okay, we'll get that, and they get it to them. Then there's a anesthesiologist, the person who's monitoring the patient to be sure they're asleep, they're comfortable, and their vital signs, their blood pressure, heart rate, breathing is all normal. And so, however many that is, 5, 6. Sometimes more, because sometimes we have 3 or 4 surgeons in a big surgery that requires multiple types of surgeons. We may have multiple, and there'll be multiple assistants and multiple circulators and multiple scrubs. And it can get busy, but usually about 5 or 6 people. All right, we'll do one more question in the pink. I think it's pink. Start.
When you have a pretty bad tumor, do you get any warning that, like, do you get headaches or something?
Well, I know that this is always the tough part talking about medical things. So headaches are common, and the vast majority of headaches are not tumors, okay? Occasionally, or I would say rarely, is a headache a sign of a tumor. So typically tumors are found because there's other things going on besides a normal headache. So you get a headache one day and you go to sleep, or you take a pill and you get better the next day. That's not a tumor. But if you had a headache and all of a sudden your leg's not working, well, that might be a tumor, or you're going blind, that might be a tumor, or you have a seizure, that might be a tumor. But a normal everyday headache is usually a normal everyday headache. The phrase that we use in medicine is when you hear hoofbeats, think horses and not zebras. So when you see something that's common, don't think of the rare thing. Headache, you don't automatically think brain tumor. You think headache. Headaches are common. They're normal. Everybody gets a headache every once in a while. That's not a sign of a tumor. So usually there'd be something else going on. So don't worry. If you get headaches, don't worry too much about it. Now, if you had something else going on or the headaches are getting worse, well, yeah, maybe see a doctor and see what they say. I can't diagnose you from here. All right, I think it's time because you guys got to get to your thing, so I'm going to go. Thank you.